Hello and welcome to the Dismantling You podcast. I'm Lisa Pineda, and today we have an incredible guest, Dr. Marco Mouanness. Welcome, Dr. Marco.
Thank you. Thank you for having me, Lisa.
My pleasure. I'd like to dive in by getting to let our audience know you first. Dr. Marco is the co-founder of Rejuvenating Fertility Center, named the world's most innovative fertility clinic in 2024. After finishing his OBGYN training at the prestigious American University of Beirut, Dr. Marco completed his reproductive endocrinology and infertility REI fellowship training with Dr. Murhi in New York. During his training, he received multiple awards for academic achievements and teaching and presented in several international conferences. Dr. Marco is a published author and expert on several fertility topics, such as ovarian rejuvenation, PCOS, endometriosis, recurrent implantation failure, and the impact of COVID-19 on fertility and pregnancy. He secured back-to-back oral presentations at the prestigious annual conference of the American Society for Reproductive Medicine, ASRM, the latest of which earned him the 2023 ASRM Prize Paper Award for his work on cost-effective medication for ovarian stimulation. He also served as an abstract reviewer at the ASRM conference in 2024. So Dr. Marco, I've known you for quite some time and we have a special connection. We did a live embryo transfer together with one of your patients and my former yoga student. I'm so lucky to have you here today. I love that you're so compassionate and you're so authentic with your patients. Tell us a little bit about your journey and what led you to fertility medicine.
First of all, thank you for that introduction. Really, I'm always humbled by the information when other people read it. Thank you so much for this lovely introduction. This whole path through fertility has been a journey. My background, as you said, I trained in the American University of Beirut in Lebanon. So I'm originally born in the US, lived my whole life in Lebanon, grew up in Lebanon, did my medical school there, my residency there. And then I came to the US to do my fellowship, and we built RFC from scratch here with Dr. Murhi. And fertility has always been in the back of my mind as one of the medical specialties that I would like to pursue. It all started with wanting to be something in between surgery and also having clinical impact, patient's impact. And I found that OBGYN encompasses both surgical procedures and also having that touch of patient rapport. Once after I went into OBGYN, I remember I believe it was in Italy. I was in Milan for a conference presenting an article. And I got into a cab and I was speaking to the cab driver who happened to be a woman there. And she's telling me about her story with fertility and how she struggled just because she was at a certain cutoff where they allowed or did not allow treatment. And she had to undergo treatments in other countries because that country was not allowing her to do treatments anymore because she was 42 instead of 41 and in 11 months. And it resonated with me that I could help these patients, that they still should be given the chance to try. And once after I finished my residency, I decided that's where I wanted to go with fertility.
What an amazing story. And it's just so incredible to hear what experiences led you to where you are today. What are some of the things that someone should look forward to with you on their very first fertility visit? Do you recommend they bring their records or even a partner or a significant other with them?
So the first visit in a fertility setting is very important. The patients come to us with the intent of divulging information that is very sensitive. Patients are vulnerable. So you want to create that trust with the patients. So my initial consultation with patients, I focus on them being comfortable, being able to relate the information they want to relay to me, and make sure they feel that I'm a trustworthy person, that they can give me their medical information, and I'll help as much as possible on my end. Bringing a relative or a significant other or someone who is a support system would be a very important point for a patient. Support is very important. As I said, they're making themselves very vulnerable, and therefore it's very important for them to be able to have someone to fall back on in case they need that help. And yeah, medical records are also very important. we use that medical record as a blueprint for our future diagnoses and treatments. That doesn't mean that we won't do any new treatments, but it also means that we will review their past history and tailor their treatments according to that as well.
Good to know, especially since that first visit can be so daunting.
It is very stressful for patients indeed.
So let's talk about, what is your take on conventional IVF versus mini IVF, the pros, cons, and who it may be good for?
So I want to start by saying there is no protocol that works for everyone. That's very important to know, right? We want to make medicine that is tailored for patients, per patient. So case-by-case medication, that's what matters. Every person who's trying to say, this is going to work for everyone, this is going to work for everyone, those people are wrong. It needs to be a tailored approach. There are pros and cons to each treatment, and this is where you want to assess, is my patient going to be benefiting from this treatment versus another treatment? So the conventional IVF usually uses higher doses of medication. It uses injectable medication that can sometimes be given multiple times during the day. So, and we know that the cost of medication in IVF is very high. So the cost is going to be high, the harm is going to be high as well. You're going to be injecting a lot of meds. That's all of these are needles. And it also entails a lot of testing, ultrasound, blood tests, etc. So the patients go through a lot. Their hormones change during this cycle, and they report a lot of discomfort during this whole process. So this is where mini or gentle IVF came into light. You can call it whatever you want, a gentler approach to IVF, a mini IVF, or just gentle IVF is what we call it in our clinic. The purpose of that gentler approach is to, 1, decrease the cost on the patient, 2, make this whole process more comfortable, 3, use a medication that is more suitable for the patient's quality of eggs, and 4, get a better outcome when it comes to treatments for creation of embryos. The higher dose medication can be okay for some patients, especially young patients that are just doing this for, let's say, male infertility problems, or for patients that have other issues. But for patients that have problems with egg quality, or for patients that are of advanced maternal age, this is what we consider part of the demographics in fertility. So for these patients specifically, using the gentler approach might benefit them in creating better quality embryos at the end of the day. And there are many studies on that. And a lot of clinics are shifting the trend towards using lower dose medication and gentler approach.
So then why, given the overall benefits for a mini IVF, why don't doctors use that protocol more often?
So it is now more often that they are using it. We have been using it for the past 5 years at least, but other clinics right now are using it as well. The trend in the US takes time to shift. You don't expect change overnight. We are seeing even with that, we are seeing a lot of changes in clinics where they are using more gentler approach. However, what I'm seeing is that they're using the conventional on the patient. They're waiting for it not to work, and then they're saying, okay, let's try something else. Maybe the gentle IVF might be a better approach for you, or the mini IVF. It just takes that, in my opinion. And we will probably see within the next 10 years a huge shift towards a gentler approach. We're not in the business of banking eggs or just creating eggs and just freezing them. We are in the patient's perspective. We are here to help them, and we are here to help them create a family. Therefore, creating embryos that are good quality is the best measure, not the number of eggs that we're going to get. So one of the cons of mini IVF is that sometimes you can get lower number of eggs. Not all the time. Sometimes you can get lower number of eggs. And this is where patients get scared, because there are statistics, right? If you get a certain number of eggs, this is how many percentage of them is going to fertilize, and this is how the percentage of them that is going to make an embryo, and this is the percentage of them that is going to make you pregnant. So if I'm starting with a lower number, that percentage is going to make it drop so much quicker. Studies have shown it's not true. The purpose of doing the gentler approach is that even if you start with a lower number sometimes, the quality is going to be better, your outcome is going to be better at the end of the day.
Good to know. And, I'm a former mini IVF person, so all it takes is one good egg.
That's true.
The bottom line, right?
That's true. An embryo or a baby comes from one egg. They don't come from 20 eggs. We know the statistics, right? But all it takes is one good egg that's going to make you a baby.
Absolutely. And I have a 14-year-old to prove it.
And we have many patients.
Yes,
as well.
Exactly. So what do you think about thin linings in an egg transfer. What is the cutoff?
So just to confirm, you're talking about embryo transfers, right? So when we take samples from a patient, female patients, those are eggs, and then we take sperm from a male, either donor or the partner, then we make an embryo. We fertilize the egg, that's an embryo, and this one we want to put back. We put back embryos. We don't put back eggs, we put back embryos. So it's called an embryo transfer. Now, the uterus is the receptive part of the whole process. The lining of the uterus needs to be a certain thickness in order for you to have a good chance of implantation. Studies have shown that the cutoff usually is above 7 millimeters to have a good chance of implantation. Some patients have thin lining, so they have problems producing a thicker lining for implantation. There are different methods that we can do to increase their lining's thickness. That includes medication, whether it's oral, vaginal medication, or sometimes injectable medication. There are sometimes structural causes inside the uterus that could be preventing it from building the lining, and therefore doing an evaluation with a scope, like a hysteroscope, which is a camera that goes inside the uterus and evaluates inside. That's also an option. And we also have other treatments like uterine PRP and other alternative treatments that can help build the lining. And actually, uterine PRP has been shown to be beneficial for patients with thin endometrial lining and for patients with recurrent implantation failure, or for patients that have a history of severe scar tissue inside the uterus called Asherman syndrome. And all these patients will benefit from that uterine PRP to thicken their lining, making it more susceptible for implantation. However, it's very important for patients to know that the lining is not the only aspect of success in an embryo transfer, specifically not the thickness of the lining. So a lining can be very thick and still be not receptive, or vice versa.
Good to know. And I was at the cutoff, so.
And I've had a lot of patients with where we had to transfer at 6 millimeters, 5.5.
Wow.
6. We like to get at least
pushing
6.
it, right?
Pushing it, exactly. And they've had successful outcomes.
Good for them.
If you've tried everything, this is the max they're going to get, it's still worth it to try sometimes with that lining. And we've had good outcomes with that. 7 millimeter just increases your chances of good lining thickness, and maybe above 8 or 9 sometimes it's also good as well.
So when doing an IVF cycle, which is better, fresh or frozen, and why?
Good question. As I started to say, there's not one protocol that's going to work for everyone, right? There are benefits to the fresh transfer, and there are benefits to the frozen transfer. A fresh transfer entails to retrieve the eggs, fertilize them with the sperm, and then transfer them in the same cycle. So it will be probably 3 or 5 days after the retrieval. This requires certain aspects of the cycle to be correct, otherwise we cannot do a transfer. 1, your lining of the uterus, the thickness of the lining needs to be at least 7 millimeter. That's 1. 2, it's recommended not to have high dose medication during that cycle because it could impact the receptivity even if the thickness is correct. And 3, you should not do a transfer fresh if you are at risk of ovarian hyperstimulation syndrome. I'm not sure if you know what ovarian hyperstimulation syndrome is, but for our listeners who might not know, this is one of the complications of IVF, especially when we use high-dose medication, where we stimulate the body too much and it creates too many eggs, that it causes problems where you can accumulate fluid in the abdomen, you can have a lot of abdominal discomfort, it can cause sometimes the ovaries to twist and cause severe pain, and it could sometimes lead in very, very small percentages for the patient to be admitted to the hospital, require IV infusions, and sometimes drainage of fluid. Now, if we do a transfer in the same cycle in patients who are at risk of this, they have much more risk of developing OHSS, hyperstimulation syndrome, and we don't do that. So, just to summarize, I would recommend to go for a frozen transfer if we're doing genetic testing on the embryos, that's 1. If the lining is not good, if we took too many meds during the cycle, or if they are at risk of ovarian hyperstimulation. These are the main reasons. There are other reasons, of course, but these are the main reasons. Otherwise, fresh and frozen have almost the same success chances if all of those parameters are correct.
That's great statistics. Good to know. What are some of the root causes of a failed transfer?
So there are a lot of causes there are many causes. There are some causes that are hormonal, other ones that are structural. There are immunological factors that could impact implantation, and there are embryo-related factors also that could cause implantation failure. The most common cause of implantation failure is the fact that the embryo is not genetically normal. That's why there's a lot of shift in recent years to do genetic testing of the embryos. I'm not saying everyone should do genetic testing of the embryos. I'm definitely not saying that, and I'm not the type of physician who would say you should all do this or you should all do that. There are benefits to doing the genetic testing. One of them is making sure the embryo is genetically normal prior to transferring it. That way you give the embryo the highest chance of success. That's the first. Other reasons, as we said, are structural inside the uterus. So for example, the presence of a fibroid or a polyp or scar tissue inside the uterus might prevent the embryo from implanting. That's the second one. A third one includes hormonal imbalances during the transfer cycle. So if your hormones are not adequate during that cycle, you might not allow that embryo to implant. And that's usually observed during your monitoring. So it's something that the clinic would usually look out for. And there are other causes that are less common, like coagulation problems, immunological problems, and other factors in the woman's receptivity when it comes to difference between the embryo and the woman receiving the embryo that could impact implantation. And these can all be worked out in case we have failures, but we start with the first ones that I mentioned.
So how would you help a patient who can't get to the blastocyst stage? I know that when I was going through the whole process, I wanted blastocysts to be transferred because they had the highest rate of success. And at that time, you could even get a 3-day embryo, transfer if you wanted, but now it's blastocyst stage, correct?
So, very good question. What I see most commonly is that patients are focusing on one thing. They say, take a word, blastocyst, and it becomes their goal. And again, as I'm saying, I'm not a cookie cutter kind of person, so each patient is going to be different. The purpose of the blast, initially, when it was the reason why they started developing embryos to blast, was to be able to do genetic testing on the embryos. Because originally, embryos used to be transferred on day 1, day 2, day 3. But at one point, with the era of genetic testing, we were able to do testing on the embryos. However, it required a certain number of cells to be taken out of the embryo, around 5 to 6 cells. Now, on day 3, embryos have around 6 to 12 cells. If you're taking 5 to 6, that's almost half of the embryo, if not all of it. But it's a lot. So the purpose was to grow the embryo up to day 5 in order for us to have around hundreds of cells, in order to take some of those cells from them and not impact the embryo's outcome. This is why initially blastocyst was pushed for. Now, at one point, we started to realize that there's a big drop of number or percentages of embryos between day 3 and day 5. Almost 50% of embryos don't make it between day 3 and day 5. Does that mean that the embryos are not good? We don't know. It could be that the lab is not the natural environment for that embryo. We try to make the lab as good for the embryos as possible, but it's not going to be 100% like the incubator, the natural incubator, which is the body. And this is why we start thinking, for some patients that we currently don't make blastocysts, why not revert to day 3 embryos and do a transfer without genetic testing? The risk is you might implant and have a pregnancy and find out at 3 months that unfortunately that embryo is not normal or that baby is not normal and you need to make a decision. However, the percentage of that occurring is also very low because most genetically abnormal embryos don't implant. And then the ones that do implant and they are genetically abnormal, they tend to have miscarriage very early on. So within 6 weeks of pregnancy or chemical pregnancies, which we'll talk about maybe. So most of them won't make it to that stage, but there is a certain percentage of patients who will make it to that stage. And this is where you're going to have to make a decision on whether to continue or not the pregnancy. So the blastocyst stage was mainly to do genetic testing to be able to select the best embryo out of 20 embryos that you have. I have this one's genetically normal, perfect, great. I'll start with this one, whereas the other ones are not. It's just the time to pregnancy is quicker. But genetic testing does not increase your pregnancy rates, cumulative pregnancy rate in general, it just increases your time to pregnancy by selecting the best embryo.
So you touched upon it. Can you explain the causes of a chemical pregnancy?
Yeah. So as I said, one of the most common causes for chemical pregnancy is abnormal genetics in an embryo. So that's the first one. Because abnormal embryos can still implant and they will start to grow. And as they grow, when the cells split and they have abnormal chromosomes, the inner mechanism of the cell is destroyed. So it causes it to break down and just stops continuing. That's one. Two, there are causes inside the uterus that might prevent the development of an embryo. So just to go back, what does chemical pregnancy mean? It means the embryo implanted, it started to grow, and then it stopped. Why did it stop? One, genetic abnormalities inside the embryo. Two, there's not enough blood flow to that embryo. So a structural cause inside the uterus, like fibroids, polyps, scar tissue that don't allow the blood to enter to the embryo enough for it to grow. And three, rejection of the embryo by the body, which is like immunological problems or coagulation problems.
Mm-hmm.
So these are the main causes.
Can antibiotics help with recurrent miscarriages?
That's a good question because it's still debated. So most studies have shown so far that treating with antibiotics for patients that have had recurrent miscarriages without diagnosis of infection will not help. However, if a patient has recurrent miscarriages, it is recommended to do a biopsy of the uterus to check for inflammation or infection. Because if there is an inflammation or infection, some studies have shown that if you do treat it with an antibiotic course, it could help with implantation later on. Still not 100%, still debated, but the consensus is if you have recurrent pregnancy implantation failure, not recurrent miscarriages most of the time, so recurrent implantation failure, or sometimes recurrent miscarriages, it's better to biopsy the uterus from the inside, check for the presence of inflammation, and if it's there, to treat it with antibiotics.
So let's talk about sperm. What causes low sperm morphology?
A lot of issues cause sperm morphology. As fertility specialists, gynecologists mainly, we usually treat the females. For male extractions of sperm, they have to go to urologists.
Mm-hmm.
But when we do fertility treatments, male patients produce a sample of sperm by ejaculation, masturbation and ejaculation. That one, we handle a sample of sperm and we can use it to fertilize eggs or to use it for inseminations or for testing like semen analysis and sperm freezing.
Mm-hmm.
However, we don't do, as gynecologists, we don't do procedures to extract sperm, which are called testicular extractions, whether microscopic or not. Those ones are done by urologists.
Mm-hmm.
However, we know the causes of abnormal sperm development, abnormal sperm formation, problems with sperm DNA fragmentation, all of these we are able to manage, we are able to help patients with to a certain extent, after which we do refer to urologists. You were asking about what are the causes for morphology abnormalities in sperm. So when we take a sperm sample, we look at different parameters. We look at the quantity of sperm, concentration. We also look at the morphology, which is the shape of the sperm. We look at the motility, which is the movement of the sperm, how much it's moving percentage-wise. And other parameters that are also important. I'm not going to go through all of them, that's a lot, but those are the main factors. When it comes to morphology, it means, as I said, the shape is abnormal. The factors that could influence developing abnormal sperm morphology include age. For men, it's a little bit older than for women, so I would consider anything more than 55, 65 even, abnormal, advanced age, I would say. Otherwise, it's not really that much of a difference. There are toxins that could, in the environment, that could affect that. Smoking, alcohol, drugs, other medical problems like diabetes that are untreated. A varicocele sometimes can cause, which is problems with the venous plexus of the testicle. So the blood flow to the testicle is not being drained properly, causes a lot of heat. There's a reason why the testicles are outside. So they are a little bit cooler. If there's a lot of heat next to them, it could impact the production of sperm. Other lifestyle factors like obesity can also impact morphology of the sperm.
Can men boost testosterone naturally when trying to?
Yes, and it's definitely recommended to do it naturally, not with medication. So unless you have been diagnosed with low testosterone by a urologist that recommends for you to take a certain dose of testosterone to keep up your dosage, men should not be taking testosterone for fertility. If you take testosterone for fertility, presumably for fertility, without consulting a physician that prescribing it to you, it will actually do the opposite. You will have no production of sperm. The brain works in a way that it gives a signal to the testicle to create sperm. If patients take testosterone exogenously, so oral tablets of testosterone, the brain will think, oh, my body's producing great. I don't need to give it any signals to produce more testosterone. So it will shut down the production of testosterone and sperm from the testicles. So Do not take meds unless you're recommended. However, natural ways is recommended. For example, exercising, lifting weights, eating high content of protein, eating high quality fats. Some vitamins, like vitamin D, has also been associated with good quality sperm or increasing the quality and the morphology of the sperm. Other vitamins can also help. We can dive into them, but there are a lot of vitamins. I usually recommend for my patients take vitamin D and CoQ10, so CoQ10. And obviously, refrain also from smoking, alcohol, drugs, all that could impact as well. Alcohol has been shown to impact testosterone production by the body, so it's definitely recommended to decrease alcohol consumption as much as possible.
Good to know. So switching gears, I have a list of rapid fire questions. Are you ready?
Go for it.
Okay, great. I want you to rate these fertility topics from 1 to 10. The first one is PRP for diminished ovarian reserve.
I would rate it at 9 out of 10. For diminished ovarian reserve, you want to do as much as possible to give your patients the best outcome. PRP will help with the quality, sometimes with the quantity, but mainly with the quality. So what we're doing with the PRP to the ovarian reserve is that we are pushing that single or 2 or 3 eggs that are coming out to be at better quality. And the purpose of all this, as I said, is quality. So we don't want to use high dose medication or do a lot to counter effect that. So coupling the PRP with good, gentle approach of IVF, or even natural IVF for patients with very low ovarian reserve, will give you the best outcome.
Botox for pelvic pain.
We discussed this a little bit with yourself and with other patients at one point. So Botox for pelvic pain has been used in specific cases in patients that have had something called vulvodynia or vaginismus, which are problems with pain or with severe contraction. So what Botox does is that it relaxes the muscles, basically. So anything that is used for patients that have problems with too much spasms, pain in the area, that can help. But in general, for fertility, I haven't seen it help in certain cases unless it's related to these specific practices. And definitely it should be given by a medical professional, preferably a gynecologist that knows the area and knows where to put the Botox.
Ozone sauna therapy.
From 1 to 10, I would say it's around a 6, just because it's per case. Ozone alone is not as potent, so it would benefit with other supplements or other treatments. For our viewers that don't know what ozone is, so ozone is a layer of oxygen that is present above in the atmosphere. So it contains 3 molecules of oxygen, whereas the oxygen that we breathe contains 2 molecules of oxygen. Most of the inflammation in our body has been due to free oxygen radicals that just attack cells and cause breakage. So the purpose of the ozone is to go as 3 molecules, link to that 1 molecule, form 4, and then split into 2 oxygen molecules that are the breathable, non-toxic kind. So it's basically neutralizing toxic oxygen radicals in the body. Dr. Murray, my co-founder of RFC, he's the one that pioneered all the treatments and studies of ozone. The only reason I rated it at 6, not higher, is because we are still doing studies on it. So we have studies right now that are going on endometriosis pain treatment with ozone, on sperm production with ozone, which actually we have presented previously also in the ASRM with great feedback, and has helped with the quality and the quantity of sperm. But I would rate this at 6 out of 10 because it still needs more studies to see the final outcome. The most it has been shown to benefit are for patients that have a thin lining and recurrent implantation failures.
So last question, I like to ask all my guests what they like to do away from work for self-care and to de-stress. I don't know what does that away from work mean, but yeah, mostly I have 2 kids. And my wife, of course, they take up most of my time. I love to hang out with them. They're still very young, so they're very attached to me. I think in maybe 10 years, they probably don't want to have anything to do with us anymore. So we're taking the time to really be with them and be full in that experience. I also love to visit new places, travel, and cooking. I love cooking. I'm a very big fan of the culinary arts, so I try to dive into that. That's great. It sounds like you have a variety of things to do when you're not working, especially as an REI. That can be overwhelming, and it's important that you don't suffer from burnouts. Kudos to you.
Right? Kudos to the other physicians who do much more than us, who do night calls. Those are the real heroes there. We just try to help our patients as much as possible.
So tell our viewers where they can find you online and your preferred social media.
Yeah, we have our website, rejuvenatefertility.com. So this is our clinic's website. And I have my own social media, dr.marco.Mouanness on Instagram. You can find me there, very easy. I try to be as active as possible. Don't hate me if I'm not, if you follow me, but I try to stick there. Every once in a while, I'll be more and more informative.
Well, thank you so much for coming and joining us today, Dr. Marco. I learned so much from you, and our community appreciates and values you so much. Thanks again.
Of course, thank you so much for having me, and hopefully you continue with all this. It's great.
My pleasure.
Thank you.
Thank you.